Okay, it's 12:30. We'll get started. Thank you everyone for joining us today for Medicine Grand Rounds. We have one of our own, Dr. Larry Istrail, here with us today. Dr. Istrail is a hospitalist here at Inova Fairfax Hospital, and he's the director of point-of-care ultrasound for the internal medicine residency. He is certified in point-of-care ultrasound by the Society of Hospital Medicine. He has authored multiple POCUS-related studies and books and is going to talk to us today about the history of the pulse and how the wisdom of the past can help us understand how POCUS can diagnose multiple diseases by simply looking at the common carotid pulse with ultrasound. He has helped really educate a lot of our residents in ultrasound and literally wrote the book on ultrasound. So we're lucky that we have him here and that he's going to share more of his wisdom with us and teach us today about examining the pulse. So, Dr. Istrail, the floor is yours.
Thank you so much for having me. So this is a unique topic, I would say, that is not usually covered, and so I talking today mostly about the idea of that the ultrasound handheld ultrasound can be kind of like the modern day sphygmograph, which we'll talk about what that is. So the teaching points, or I want to understand a little bit of the history of sphygmology and how it's relevant today. The principles of pulse wave Doppler and how you can use it when you're examining a patient at the bedside. And then like what different things you can look for, rule out, rule in using this tool. So what is sphygmology? It's just the study of the pulse. And it was started by this guy, Herophilus, a long time ago, when he was around 300 BC. And he came up with roughly four characteristics of the pulse: its size, frequency, force, and rhythm. He was also known for using one of these clever pots over here, which is a water clock, which lots of different societies had, but it was essentially a pot with a small specified hole at the bottom, so they would know how long it takes for a certain amount of water to drain out, and they would use that to measure the pulse. And then many years later, there was another doctor named Galen of Pergamon. He recognized the association of the pulse with the heart. He recommended feeling at the wrist, and he thought that you should feel it in health to understand how it may deviate when someone's sick. Many years later was a guy by the name of Avicenna, and he wrote this textbook that would be in use until 1650, the Canon of Medicine. And he had all sorts of insights, many that are even relevant today. And so I included a couple here that I thought were funny or interesting. This is one. Wine has a notable effect on the pulse in that, if taken plentifully, being attenuated in nature, it gives rise to an irregular pulse. So this is like the holiday heart that we learn about. And this unequal pulse is not altogether irregular, supposing it to have no equality and yet to preserve a certain period, such as to extent of diastole, etc., etc. If it not only had no equality, but also no order in its equality, such a pulse would be not only unequal, but also irregular. So this is, to me, like early description of atrial fibrillation. So a little bit more modern, in the early 1500s, there was a Dr. Struthius. He was a physician for the Polish royalty, and he wrote this book called Ars Sphygmica in the 1500s. And he's notable for reportedly being the first person to make a graphical tracing of the pulse by putting a leaf on his radial artery and just kind of seeing how the radius would, the leaf would move as his pulse happened. And so he actually drew it out here. This is an actual screenshot from the book itself, and this was in Latin. It was translated by ChatGPT. And so it said, a convulsive pulse resembles the string of a bow when stretched tightly, drawn with slightly curved lines like this. The vibrating type, however, is represented by lines highly inflected upwards and pointed. So that was interesting. This was from 1602. And then fast forward about 200 years, this guy, Carl von Weroort, he invented the sphygmograph, which is very similar in appearance to one of the lie detectors you would see on a movie, and is essentially a little pressure sensor that would sit on the pulse, and then this machine that would trace it out. But it wasn't really used as much until Dr. Marie improved upon it and made it much more usable and practical. So here's a picture of what he created. And so here you can see the little pin that sits on the radial pulse and measures the pulse going up and down. And then it has a little pen that kind of draws the graph here. So by 1880, there were multiple lectures and books on this field of sphygmology but using this sphygmograph now that they had. So it was really revolutionary for the time. This was a Dr. Byram Bramwell. And he wrote that, this was from his lecture, and he wrote that the upstroke in the normal pulse tracing is nearly vertical. It corresponds to the shock which it communicated to the whole arterial system by the sudden bursting open of the aortic valve. So you can see here when the pulse hits, it goes extremely vertical and you have a nice sharp peak. The direction of the line of ascent, vertical or oblique, depends on the condition of the aortic segments, and this is very relevant to what we're going to talk about soon, or the suddenness of the ventricular contraction, where there is no obstruction to the free opening of the valve cusps and where the contraction of the ventricle is sudden, the line of ascent is vertical. So in other words, in a normal aortic valve, the line of ascent is vertical. Vice versa, when there is stenosis of the aortic orifice and where the ventricular contraction is slow and gradual, the line of ascent is oblique. So here, if this was a normal, you have a nice sharp peak and a gradual decline, whereas here, the sharp peak kind of disappears and it becomes more rounded. And this was another example from his lecture. And so if you look at examples from his 1880 lecture, here is normal, here's patient with aortic stenosis, and you compare it to a pulse wave Doppler from 2024, I mean, it's very, very similar. So you have the exact same sharp rise, sharp peak, and gradual decline. Likewise, with aortic stenosis, very similar as well. You get this not a vertical ascent, a more oblique ascent. You get a rounded apex, and then the ascent and the descent are very symmetrical. So how can you use ultrasound to assess the common carotid artery? Let's just talk briefly about what Doppler is and the differences. So there's color Doppler, which I'm sure many people are familiar with, and there's pulse wave Doppler. The way I like to think about it is like if you're in a helicopter above the highway, you can look down and see kind of the overall trend of which direction the cars are moving, the average speed of all of them together. That's really what color Doppler is. And then if you want to know instead a zoomed in lane on the highway and you want to know more quantitative information like how fast are those cars going exactly, then you would use pulsed wave Doppler. And these green lines here are the Doppler gate, which we'll talk about. So for color Doppler, this very basic overview, but essentially the ultrasound probe sits on the skin and it emits an ultrasound wave, multiple ultrasound waves at a certain frequency, and then it bounces back to the probe. And based on the time difference, the probe can determine the velocity essentially. And so the faster the red blood cells and the other cells are traveling, the faster the return frequency will hit the probe. So that's the basic idea, and it will get you an image something like this. So if you can see over here, this is the longitudinal or head to toe axis of the ultrasound sitting on the carotid artery right here. And so this probe marker is indicating that this is going towards the head and this side's towards the feet. So what you're seeing is a red inside the artery, and that's telling you that it's roughly this velocity. So if it gets to yellow, it's 28 centimeters per second. So this is probably like 20 something. So it's telling you the direction of the blood flow in relation to the probe. Red is towards the probe, blue is away usually. Okay, so that's what that can tell you. And then with pulsed wave Doppler, it's same concept, but now you have a Doppler gate. So you're saying, I want to know what's happening exactly between these two blue bars. And I want you to graph it for me with velocity as the y-axis and time as the x-axis. And so you get, instead of just a color, you get a graph. And cells going toward the probe are going to appear above the baseline here, this green line, and cells going away are going to appear below. okay? So this is just a quick example. So you can see the probe is placed on the transverse view on the lateral neck. This will repeat, it's very short clip. And then you get the pulse. This is the Doppler gate right here. And the arrow is telling you to put it in direction of the blood flow. Here we put on color Doppler to confirm the vessel. And then you click the spectral Doppler or pulse wave Doppler and you get this pattern. This is a normal patient. So again, let's watch this again. So over here is the carotid right here. So you start with the transverse, then you turn the probe in the vertical axis, so you're getting the longitudinal view of this carotid artery, and then you point the arrow direction of blood flow, and we'll talk more about these other things shortly. And then you get a graph of velocity on the y-axis, time on the x-axis, okay? So what information can we get from these graphs? Well, this is a normal tracing, so you can get the end diastolic velocity or the lowest velocity before systole. You can get the peak systolic velocity, which can be very helpful. So in a normal patient, it's ranges from about 75 to 100 centimeters per second, but it can vary based on many things. And then at the end of systole, you have this dicrotic notch, which is the closure, which happens when the aortic valve closes. Okay, and then you have diastolic flow, which is above the baseline in normal conditions. So you can see here, peak systolic velocity is here, gradual decline, dicrotic notch here, and then you still have above the baseline flow. It's just very, very low here, very low velocity. Okay, so that's pretty normal appearing. You can also measure other things like acceleration time. So acceleration time is just the time that it takes from end diastolic velocity to peak systolic velocity. And that will help you determine how long it takes for the blood to exit the aortic valve, essentially. And then the ejection time is really just the time of systole. The other thing you can do is you can measure a VTI, which is a velocity time integral. And that's really just the area under the curve of a certain area. So for example, the systolic VTI is if you trace this curve just in systole, and you get a distance, because this represents the distance the blood travels in a given time. All right. So you'll get something like 15 centimeters. And then this is the diastolic. So some studies, as we'll talk later, use only systolic velocity, which to me makes the most sense. VTI, I mean, some will use total VTI, which is systolic plus diastolic. So how can you use this to screen for cardiac disease? Well, you can look at a heart rate. You can measure the heart rate. You can get a good idea what the heart rhythm is, although it's not as precise as an ECG. You can pretty accurately diagnose or rule out aortic stenosis. You can diagnose aortic regurgitation when you see certain things. And you can also diagnose low flow states and potentially calculate cardiac stroke volume and cardiac output, which we'll talk about. So if you look here, just some 4 examples of the heart rhythm, which I think anyone would be able to figure out what they are. You know, a normal sinus rhythm, nice normal waveform, equally spaced, atrial fib. You can see just random appearance of VTIs and the peak systolic velocities. SVT and atrial flutter very regular. So it gets you at least an idea of what's going on. And so if we want to know, does the patient have aortic stenosis? If you're admitting an elderly patient with shortness of breath, most people, I would say, the vast majority of clinicians seeing a patient at the bedside are not going to be able or capable to do a standard diagnostic assessment of aortic stenosis, because that involves, requiring an apical 5-chamber view of the heart, positioning the patient appropriately. There's all sorts of ways you can have error. You have to trace the VTI. It's just very difficult. It usually requires a skilled sonographer. The other thing is, the morbidity and mortality is very, very high as aortic stenosis becomes severe. In these elderly patients that may not be moving around very much, they may not have symptoms. and there's also issues with if patient also has reduced ejection fraction or low flow and they have AS, how to differentiate that. So if we look at the carotid, this has been known since the 60s at least. This was a picture from a study from 1963 where they put this sphygmograph on this guy's carotid, and they also had an ECG tracing, and they showed in a normal patient, you'd have the QRS here, and then you'd have a normal looking carotid pulse. So relatively, this one is not very vertical, but somewhat vertical, somewhat sharp peak, and comes down here. Whereas with aortic stenosis, you can see is much more delayed to the peak. The peak is much more rounded, and the ascending and descending were pretty symmetric. So this is kind of the graphical representation of this pulsus tardus et parvis, which has been described for millennia, but it's essentially a delayed and weak pulse that people back in the day knew was associated with aortic stenosis, but they couldn't really characterize it very well. So as you can see here, the aortic valve gets more stenotic, the acceleration time increases out of proportion to the ejection time, and then the ascending slope reduces, the peak becomes more rounded, and the descending slope mirrors the ascending slope. Okay, and so this is what you would see. So as you can see, this patient has severe aortic stenosis, and their peak velocities are about 75, which is normal. Usually aortic stenosis does not reduce the peak velocity unless they're very, very severe. And you can see they're nice and rounded here, symmetric. There's no very sharp peak. And so if you look down here on the ultrasound, so what I've done was I found the carotid artery, and I put color Doppler on it initially just to make sure I was in the right place. And you can see there's blue and there's red in here. So this patient had very kind of varying velocities throughout this portion. And so I placed the Doppler gate right in the center of the vessel, and I tried to angle the arrow here to be in line with the blood flow. Okay, and then what the ultrasound is doing is it's trying to make a acute triangle angle right here. Okay, because if the way the physics of the Doppler works is if your correction angle is greater, 60 degrees or greater, it's considered not accurate. So here it's 55 degrees, so this angle here. So you may have to move your Doppler gate around when you're trying to measure this velocity accurately, okay? So that's what that looks like. So as you can see here, as AS progresses, not only does the waveform change, but certain quantitative measures also change. So acceleration time, on average, a normal one is like 30 to 80 milliseconds, something like that. As the AS gets worse, the acceleration time increases. Also, the acceleration time to ejection time, this AT over ET, also increases. So in normal, it's less than 0.25. As we get to severe, the acceleration time increases more than the ejection time, and so you get this very, very high ratio here. So how accurate, can you use this? Is this just a very specific sign and it's not sensitive? How accurate is it? And so there was a large study out of Germany where they took 1,300 patients who had a ischemic stroke who also had an echo, and they just looked back and said, how many of the people with pulsus, so they had an echo and a carotid Doppler. So how many of the people with the pulsus tardus on carotid Doppler also had severe AS on their echo? And they found that it was dramatic. There was an odds ratio of 1,270 of having moderate to severe AS if you had that carotid waveform. So that was a 92% sensitive and 99% specific for moderate to severe AS. So that's pretty impressive. Now this was in patients who had ischemic stroke. So there are other causes of this waveform that may not have been picked up in the study. Like, for example, it really just shows you that it's upstream obstruction of flow. So if you're measuring it at the common carotid, and then there's some rare narrowing of your brachiocephalic trunk, you could see something like this. If you have a ascending aortic dissection that with the flap obstructing the blood flow, you could get something like this. But more often than not, especially if you see it in both carotid arteries, this is due to aortic stenosis. And so there's a lot of studies looking at acceleration time and the ratio at the aortic valve, which correlate very well with the ones at the carotid. So they found, in a few studies, they found that the 0.35 cutoff was 70% sensitive, 84 specific for AS. 0.49, it was 100% specific for severe AS. And it was also, these patients also have much higher risk of dying. So I'm actually doing a study here right now, enrolling severe AS patients and comparing them to controls to see if we can better quantify exactly what changes as AS goes from mild to moderate to severe. So this is just a graphical representation that you plug in the ultrasound that you get, and it kind of graphs it out, and then it tries to calculate the different markers here. So what about for other aortic diseases? So for aortic regurgitation, you can also use pulse wave Doppler. So this was Dr. Dominic Corrigan in 1832 with just his fingertips and nothing else, just feeling pulses. He was able to figure out that this pulse variation was seen in aortic regurgitation. So the way he described it, when the semilunar or the aortic valves become incapable of closing the mouth of the aorta, after each contraction of the ventricle, a portion of the blood just sent into the aorta returns back into the ventricle. The ventricle again contracts and impels quickly into these vessels a quantity of blood, which suddenly and greatly dilates them. The diastole of these vessels is thus marked by so sudden and so great an increase of size as to present the visible pulsation, which constitutes one of the signs of the disease. So that was in 1832. In the late 1800s, there were case reports of doctors posting their sphygmograph tracings in these cases as well. So here was one of aortic regurgitation in a 21-year-old patient with syphilis infected 18 months prior, presented with shortness of breath. The physical exam noted a long diastolic murmur in the aortic area. The patient succumbed to his illness, and on autopsy, he noted that the aortic valve was altogether incompetent. And so this was the tracing he published in this study. And as you can see, this is what's called pulsus bisferens. Okay, so this is a nice sharp upstroke, which is normal. And then this is the dicrotic notch here. So there's a second nearly as tall upstroke here. So this is a bifringe or double pulse. Okay, so this is what these docs in the late 1800s were thinking was a sign of aortic regurg. And it's interesting because if you look at this on pulse wave Doppler, it looks pretty much identical. So here you have the systolic peak, the second systolic peak, and then here's the dicrotic notch. So for aortic regurgitation, there's really three variations you can see if you're looking at the common carotid. The first is, like we mentioned, the bisferens, the double pulse. This is where you have the two systolic peaks. Now, I've seen it in other patients that don't have aortic regurg, so it's not 100% specific to this, but if you see it, that's something you definitely need to think about. The other thing is this water hammer pulse, which is depicted here with ultrasound, and you have this diastolic reversal of flow. So here you have semi-normal looking peak, and then you have a little bit of this bisferens here, and then you have this reversal of flow here. So you have below the baseline blood flow. So this is when the blood is exiting the aorta and going back into the left ventricle here. And this is going back into the common carotid, then exiting again. Okay, and the third thing is similar that you can see is similar to this, which is zero diastolic flow, where you just don't see anything at all in between each pulse. All right, so in that same study, so this is what it would look like. So this is the water hammer or diastolic reversal that you'd see with severe aortic regurg. And so again, the Doppler is sitting in the longitudinal or head-to-toe axis looking at the carotid. And here the angle of correction is 56 degrees. So that means that this angle right here is less than 60. So you can assume these results are accurate. So in that same study of ischemic stroke patients who had carotid Dopplers and echo, the pulsus perspirans was seen in 14% of mild, 22% of moderate, and 25% of severe aortic regurgitation cases. Diastolic reversal was seen in 10% of mild, 12% in moderate, and 50% of severe, although it was only 4 cases. Zero diastolic flow was seen in 1 with no AR, 2% of mild, and 50% of severe. So in general, these findings are very, very specific but not sensitive. So in other words, you can't rule out severe AR if you don't see anything in the neck, but if you do see it, then it's very likely that it is related to AR, especially if you see it on both sides. So the last thing I'll talk about is the kind of low flow and output. So over here is a normal appearing tracing like we saw before. The normal velocities are 75 to 100 centimeters per second, but sometimes you'll see something like this where you just have a really small VTI here, and this one's rounded, this one's triangular, but the velocities are like 25 centimeters a second. And so this is called low flow, or some people have called it stump and thump appearance. And so if you see this, first you need to figure out if it's unilateral or bilateral. If it's unilateral, then you're thinking there's some sort of occlusion, either upstream or downstream. So proximal carotid artery occlusion, brachiocephalic narrowing. You could have some sort of high-grade internal carotid artery occlusion. So if you have like 100% internal carotid, sometimes the common carotid can look something like this, a vasculitis, carotid dissection. But if it's bilateral, you really got to think of a more central cause, which is usually severe aortic stenosis or something like cardiogenic shock, where just not enough blood is getting up there. And so I've seen this many times in patients with like severely reduced EF, like 15, 20%, with a very, very low stroke volume. You just see something like this. So can we estimate can we use carotid flow to estimate cardiac output or cardiac stroke volume? There's been a couple studies that have tried to do that. So to understand how you can do that, we'll just first briefly talk about how you would do it at the heart. So the way I would think about it is essentially like if you think of the heart as like a cylinder producing factory, okay? Every time the heart beats, it produces this cylinder that shoots into the LVOT and goes out to the body. So this cylinder, the way it's estimated on echo is just like the volume of any cylinder. They need the diameter here and they need the length. Okay, so the diameter here is the LVOT, left ventricular outflow tract diameter, which is measured during an echo. And then they put it into this equation, which is just a regular equation for any cylinder, cross-sectional area times length, which is here is the VTI. So remember, this is the velocity time integral, or essentially the distance the blood travels. All right, and so that will get you the stroke volume, or the volume per cylinder, and then you multiply that by how many cylinders are made per minute, or how many heartbeats per minute, and that gives you cardiac output. So similarly, if you imagine this is the common carotid, and we want to figure out how much blood is going through the common carotid in a given amount of time, we do very similar things. So we measure the diameter of the common carotid, and then we measure the systolic VTI of the carotid pulse, like we talked about. So you just trace this, and the echo machine usually can just calculate it for you. Okay, so then you plug it in here. So I actually, in the study, that what I think was the best study, they were looking at PICU patients pediatric ICU, and they did a carotid Doppler at the exact same time as the echo. And the reason that's important is because, you know, there's so many variations, beat to beat, minute to minute, hour to hour, you know, blood volume, heart rates change, things like that, that if you're not doing it very similar time, it's hard to get precise results. But in this study, they did it at the exact same time. And they found that their linear regression equation for stroke volume was this. So in other words, you get a carotid stroke volume like we talked about, and then you multiply that by 8.86, subtract 0.5, and you should and that would estimate the cardiac stroke volume. All right, so, and this was from the study. So what they found was pretty remarkable, that the CBF, which is the blood volume going to the carotid, and the S here is systolic. So just like what we talked about, this number here, it correlated nearly perfectly, and this was the equation. All right, and here was, they calculated cardiac index here from the echo, and then they calculated it from the carotid, and the association was pretty much perfect. So here's an example in a patient with aortic stenosis in our study. So over here on the left is the common carotid artery. Okay, so you take a transverse view, and then you measure the diameter. So this one was 0.91 centimeters. Then you get the pulse wave Doppler tracing, and you trace the outline of the systolic and VTI, and then it calculates it for you. So this one was 8.51. And then this patient at the time, his heart rate was 84. Okay, so we just measure it again like we would any cylinder. We measure pi r squared times the systolic VTI, which is 8.5, and here, and so we get 5.53 ml. So that's the carotid stroke volume. All right, and then we plug it into that equation from Rubio, that from this study here, and we multiply 5.5 times 8.86 minus 0.5. And so we got 48.8 ml as the estimated cardiac stroke volume. And then multiply that by the heart rate, you get estimated cardiac output of 4.1 liters per minute. Okay, and then in this patient's echo, these were the actual numbers. So stroke volume was 57, and the cardiac output was 4.7. So very close estimate. So yeah, that's all I got. Happy to answer any questions.
Great. Thank you so much, Dr. Istrail. Let me allow everyone to unmute themselves, and then we'll allow for questions real quick. Alrighty. Let's see, Dr. Batchelor, I think you have your hand up first.
Yeah, thanks, Larry, for just an excellent presentation. I really enjoyed particularly the historical perspective that you presented, where folks have been looking at this for literally centuries, and now our ability to really hone in on some of these key hemodynamic findings has really reached a critically important level. Aortic stenosis is quite common as you get older, and the prevalence is about 3 to 5% over age 75. So some of these techniques that you're describing I think are going to be critical to the evaluation of patients, especially potentially for screening higher risk patients. There are two recent studies that show in the literature, the cardiac literature, two randomized trials that show benefit of TAVR or valve replacement in patients who are asymptomatic and have severe aortic valve stenosis. So those folks are not easy to find, because if we're not listening to heart murmurs carefully, we can miss them. So the work that you're doing is, I think, going to be very, very important in the future for just handheld devices in offices and in hospital settings for detecting these patients, because I think the guidelines are probably going to change to the point where as soon as we define severe aortic stenosis, we probably need to treat it. So just want to emphasize that point, maybe get your feedback on how do you envision, assuming that it's going to be important to pick up asymptomatic aortic valve stenosis. How do you envision using this, and how would you set up a study that might validate some of the work that you're doing in that particular patient population, the asymptomatic severe aortic valve stenosis patients?
Yeah, thank you. Yeah, I mean, I think ideally this should be like we look at the vitals, we look at the neck vessels. I think there's another study we did where we showed that you can do a very similar thing, but with the jugular vein, measure an accurate right atrial pressure. So if you do that and then you look at the carotid and you get a waveform and systolic velocities and or the VTI and a few other things in our study that I'll talk about, then I think that gives you like a really nice overview of what's going on and something that can be followed over time in a PCP's office or when a patient comes in for shortness of breath. Certainly, in my opinion, every single one of them should get a carotid and jugular ultrasound. But yeah, it's one of the reasons I wanted to pursue this is because it's pretty easy to do. It's super easy to see the artery. It doesn't need a lot of skill like cardiac echo. Trying to get a PCP, for example, who's never had any experience with ultrasound, I think this is a great way to do it. And to address your second point, yeah, so there's a study ongoing right now that I'm doing where I'm enrolling any patient with AS here getting a TAVR that day. So we enroll them before the TAVR, and I scan both carotid arteries, and then we look at the shape, but also there's the software I showed you briefly that calculates a bunch of things on it. And so right now we're at about 75 patients. And so I think it will be able to say, likely AS or not, or rule out AS, because so far what I've seen, I feel like it's something like 90% sensitive and specific, this rounded waveform. I have seen it in patients who didn't have AS, and I've seen normal waveform in patients with AS, but it's pretty rare. So yeah.
Just as a comment, it might be important to repeat, if you can, the study after the patient has had the transcatheter aortic valve replacement. If you can show very good sensitivity and specificity pre-procedure and then, show the delta and the change afterwards, it would certainly strengthen the study. Maybe something to do, maybe in a selected a subgroup that you randomly select to get in the office and have a follow-up. But terrific work. I think this is really important, especially since we're going to encroach on some of these asymptomatic patients and treat them earlier.
Thank you so much. Thank you.
Dr. Meyer has his hand up. He wants to ask a question.
Yes, thank you very much. Yes, I'm a firm believer in ultrasound. I started echocardiography in the 1970s at George Washington University, and I did all of the echocardiogram. Then I trained technologists, and it wasn't too long before the technologists were better than I was, and because they do it all the time. So my concern, and of course, now echocardiography is so complicated that, for one thing, the concept of knobology, and that is the study of how to twiddle all the knobs on the machine so that you get optimal pictures. My concern is that I don't know whether you're advocating that, say, general internists would use a machine like that versus a technologist who does it every day. If you only do it, once a day or once a week, you could get pretty cold on it. I was wondering what is your feeling about being able to train people to do that?
Yeah, well, fortunately, the new machines really don't need much knobology at all. Like the one that I use is called a butterfly, and it connects to your smartphone, and you just swipe left and right, up and down for gain and zooming. So fortunately, that's really not an issue anymore. It's really just acquiring the actual skill of doing it and practicing.
Great. Dr. Greenspan asked, how does this compare with auscultation?
Yeah, so in general, the studies I've seen, the auscultation is specific but not sensitive enough. And so if you hear the classic systolic murmur, then yes, that's likely AS, but it gets confused with mitral regurgitation murmur, or if the patient has like low flow AS, they may not have enough blood flow going through the aortic valve to make a loud murmur. So this, I think, is much more sensitive and specific, but I'll know for sure, when our study's done. But based on that retrospective study I showed, I mean, that was, there aren't many things in medicine that have that big of an odds ratio or that are that specific or sensitive.
Wonderful. Thank you. Any last questions? Dr. Batcher had a comment, said AI will make this easier, won't need much knobology in the future. He predicts POCUS will completely replace the stethoscope, and this talk is a harbinger of the future. Yeah, that's exciting.
Thank you.
Alrighty, lots of positive comments from people in the audience and the chat. So thank you so much, Dr. Istrail. We appreciate you being here and telling us about your interesting research. I'm excited to hear a follow-up from that once you get more results. But thank you everyone for joining us today. We'll have cardiology grand rounds next week. So please join us for that.